it is 28% mortality is because of cardiovascular diseases. Out of which 12 to 16% of the cardiovascular disease patients are younger than 40 years. And during my DM, I have seen the youngest patient is 21 years who was a rep and who didn't have any of the risk factors like smoking, alcohol, tobacco, anything. And the other cardiovascular risk factors are the profession itself, as sir told. As we know that diabetes, hyperlipidemia, hypertension, and hemostatic and thrombotic factors, that is protein C and protein S deficiencies, and behavioral problems. Earlier it was a type A personality. Now it has been studies have shown that even the type 4 more risk factors may be because of 38%, and there will be none of the risk factors can be seen in 19%, and one of the other risk factors with 43%. Of which 60% of those who develop coronary events have only one or even none of the traditional risk factors. More than half have either normal or mildly increased lipid values. Nowadays, earlier we used to think that TROPA and CPKMB are the more cardiac inflammatory markers, but nowadays it has been come up with the HSCRP. We had a study when I was doing my DM to the angioplasty as well as the post-angioplasty. There was a significant reduction of the HSCRP once we had seen after. In 2003, the measurement of HSCRP may be help direct further evaluation and therapy in primary prevention of cardiovascular disease. And the AHA told their guidelines that entire adult population should not be screened for HSCRP for purpose of cardiovascular risk assessment. Then down the years 2010, they told that measure CRP in apparently healthy elderly people to identify the cardiovascular risk factors. And in 2000, then inflammatory mediators released, then the atherosclerosis process starts. Here our intervention work starts. And this atherosclerosis process takes for some times, and even there are differentiation between the thin walled plaque as well as the thick walled plaque. These thin walled plaque are more dangerous compared to the thick walled plaque. In coronary artery disease, because thin wall plaque, they are very prone for rupture and cause an acute MI, whereas a thick wall plaque, they present as an unstable angina or chronic stable angina, where the patient will take some time. Once there is already atherosclerosis process has taken up. Now, how to prevent this inflammation is the next generation drugs which is coming up. As Kamredi sir already went into detail of curcumin as well as the tryptophan metabolites that HAA, which I will be dealing with in further slides. I think this slide is there, or you told me that this slide is not there. So, okay, fine. So curcumin, how it acts, already sir has discussed with this one. That is prevents activation of NFKB, translocation into the nucleus, prevents release of inflammatory markers.